Hello everyone, welcome to another video on a very important topic called abnormal uterine bleeding. And so what is the definition of abnormal uterine bleeding? It's defined as an abnormal menstrual frequency, volume, duration, and regularity of the menstrual period. And this can be defined by the mnemonic Palm-Cohen. These are the etiologies that you should know regarding abnormal uterine bleeding. So the first topic is polyps. Polyps are usually benign in nature, but they can cause bleeding, and the treatment for that would be simple polypectomy. Second of all, we have adenomyosis. Adenomyosis is the buildup, the thickening of the myometrium. You would see this on transvaginal ultrasound. The third topic, and very, very common in adolescent females after the age of 30, we have leiomyomas. Leiomyomas usually is treated with observation and surveillance, but when it becomes symptomatic and it can cause other symptoms like heavy menstrual cycles and infertility, in that case we would do removal via a myomectomy. The next topic is obviously malignancy or hyperplasia, especially hyperplasia of the endometrial lining, such as endometrial cancer. Next topic is coagulation. In the context of coagulation, the von Willebrand factor disease is the highest deal topic that you should know. It presents as a high bleeding time, high PTT, low factor 8, low von Willebrand factor, obviously, and ristocetin asset will show a failure of aggregation of platelets. The next topic we have is ovulation issues. So this includes obesity, PCOS, and thyroid issue. As you know, thyroid issues such as hyperthyroidism can actually cause menorrhagia, increased menstrual bleeding, and increased pain during the menstrual cycle, also known as dysmenorrhea. The next part is E, which stands for endometrial pathology, such as I said, endometriosis and endometrial cancer. The main cause of endometrial cancer is unopposed estrogen. An example for this would be, for example, Turner syndrome. We have PCOS. The next topic is iatrogenic. Iatrogenic causes include treatments in a medical facility. This includes supplementation with estrogen, progestins, IUD placement, and antithrombotic agents. As you know, this is simple physiology. Estrogen actually builds up the endometrial lining. Progesterone maintains the endometrial lining. And when progesterone decreases, or the plasma progesterone decreases in your blood, this is when the endometrial lining begins to shed, causing your menstruation. Now moving on to the last one, N stands for not otherwise classified. For example, cesarean scar defect, uterine arteriovenous malformations, and that concludes the Palm-Cohen system. So this covers all the main causes of abnormal uterine bleeding. So now what do we do for diagnostics? The first initial test that you should do is a beta HCG to determine whether the patient is pregnant or not pregnant. Number two is a CBC and serum ferritin, so we can evaluate for anemia, thrombocytopenia, which is a cause for bleeding, and iron deficiency anemia. Because patients who have heavy uterine bleeding or increased volume of bleeding, frequency, whatever it is, it's always a risk factor for iron deficiency anemia. And as I said, for thyroid disorders, we'd want to check for TSH to evaluate for hyperthyroidism. Next is blood cross-matching. This is used in acute uterine bleeding where the patient has lost a large volume of blood. So, for example, if we see on CBC that the patient's CBC is, for example, 6, this is the moment where we have to do a blood typing cross-matching so that we can give packed red blood cells, fresh frozen plasma, or whole blood. Next, we would evaluate for coagulation factors such as PT, PTT, and fibrinogen. This is if we're suspecting a bleeding disorder. As I said, the main one is von Willebrand factor disease. We also do this in all patients with heavy menstrual bleeding. Next is age-appropriate cervical cancer screening. Usually, as a rule of thumb, a cervical cancer screening is not indicated in patients who do not have risk factors for endometrial cancer, such as early menarche, late menopause, nulliparity, type 2 diabetes, PCOS, obesity, conditions like that. Otherwise, if they do have the conditions that I listed, we would do cervical cancer screening via transvaginal ultrasound or endometrial sampling. As I said, pelvic ultrasound for imaging, we would do endometrial sampling. In case of increased risk of endometrial cancer, as I said, nulliparity, early menarche, late menopause. OCP use is also very important, I didn't mention. Diabetes, PCOS, and obesity. Now, moving on to the treatments that we have for abnormal uterine bleeding. In the case of an acute bleeding, if the patient is unstable, obviously we would immediately go and try to replace the missing blood volume. So first we would do a cross-matching and we do hemodynamic support. Also, a very important treatment that we would give initially is high-dose equine estrogen. Now, in the case of stable patients, actually to decrease their bleeding, we would put them on OCPs, progestin, which is a progesterone analog. We would give oral equine estrogen. Here we actually give IV equine estrogen, and we would consider tranexamic acid. Actually, this applies for both cases. Tranexamic acid is used in case of profuse bleeding or active bleeding. And next is that we treat the underlying cause. Surgical options include polypectomy for polyps, myomectomy for adenomyosis, uterine artery embolization. Actually, I didn't mention this, but it's used for leiomyoma. It actually cuts off the blood supply for the actual leiomyoma, which causes it to shrink down and causes an improvement in symptoms. Now we do dilation and curettage. This is both diagnostic and therapeutic, so it can be helpful. And endometrial ablation or hysterectomy is actually used as a final line when the patient's symptoms are actually refractory to the above treatments. And that sums up the topic of abnormal uterine bleeding. Thank you very much.